Okay, so to start again, the first case, a 19-year-old boy who is immigrant from Rwanda arrived in UK 2 days back, but he has high fever, which is intermittent along with sweating as well. He was sent by GP to the emergency unit. His full blood count shows hemoglobin of 133, platelet count of 110, and the white cell count is 8. And this is the blood film of the patient because the BMS mentioned that the platelet count is low and he is junior. If you can review the blood film for him. So who wants to go first? Any volunteer? Come on, anyone? Exam is on 3rd of October. Anyone wants to go ahead? This case will come this time because it did not appear in the last exam. The first on the list is Amber Seol. Do you want to go ahead? Fatima?
Hi, good morning.
Good
Yeah,
morning.
I can give it a go. Sorry for the background noise.
No worries, it's okay. So you have heard the story that this is a 19-year-old guy with persistent fevers and he is immigrant from Rwanda. And the BMS is a new and he has noticed thrombocytopenia and he wants to have a look at the blood film.
Yeah,
So this is the power 10.
yeah. Um, I think from this distance, um, I can, yeah, I
Um,
can
I will
barely
I
comment.
will
I think. Mm.
I will show you 50 oil and 100 oil as well. Then you can report the blood film in exam style. Okay. So this is 50 oil.
Mm-hmm. Yeah, I think I. Mama, I am being quiet. Mama, please be quiet. Mama, be quiet. Be quiet, be quiet, be quiet. Be quiet. So I can, I think,
Trying to focus it for you.
mm,
I think this is better.
yeah. Yeah, I think,
Now report the blood film.
mm,
How would you report for the exam purpose?
yeah, I think I will start systematically, mentioning that, commenting on the platelets first. Um, um, I couldn't see any platelets, so it will be true thrombocytopenia, no evidence of clumps. Be quiet. And RBCs, I can see intracellular ring forms within the RBCs.
Okay, so how would you describe these ring forms?
I think I will mention it's intracellular intracellular organisms with
Malarial parasites.
pardon,
Malarial parasites.
malaria parasites. Yeah. Uh,
So the blood film contain uh, malarial parasites in the red blood cells. The size of the red blood cells are normal. The rings are thin, some with double dot shape, and some near to the red cell membrane, which are equiform. We have seen multiple um, red cells with double rings as well. The crescent form of Plasmodium falciparum is very rare to see in the blood film. Yes, you have to comment on the white cell count and platelet as well, whether they are increased, normal or abnormal, or
mm,
decreased. So the film is most likely consistent with uh, malarial infection, likely Plasmodium falciparum, which need to be confirmed on further testing, like rapid diagnostic test or and by NAT PCR by sending the sample to a reference lab.
mm.
This will constitute your report only. You have explained your finding, you have given your suspicion, which is Plasmodium falciparum, and you have suggested further testing by RDT and uh, by referring the sample to reference lab so that they can do PCR. Right. Now the next question would be, uh, what is the principle of RDT, rapid diagnostic test? So rapid diagnostic test is a lateral low immunochromatographic antigen detection test which detect the antigen produced by the malarial parasite.
Mm,
Okay. This test use a dye-labeled antibody which bind to malarial antigen, and this combination of antigen and the antibody gives you a line in the test. The kit is the same as we use for the COVID test.
mm.
So the last question would be, uh, how would you manage this patient?
I think I will say this
अभी भी मैं
patient
सहारे के नाम
has
से
been
आई हूँ हालांकि वहां पे मेरा नाम आया था यहाँ पे जो भी है
Can you repeat?
um, I think I will say this patient needs urgent medical assessment and admission. Um, so if it's a G- was it if it's a yeah, if it's a GP sample, we patients need to be urgently admitted to hospital and
The patient is in the patient is in the ED, referred to ED by the GP. So the patient is in the ED.
okay, so I will say this patient needs urgent medical assessment and discussion with infectious disease team, um, and full set of history and examination and investigations, including UNEs, LFTs, and hemolytic markers. needs to be done.
Okay. The patient needs admission either under medical team or infectious disease team if the hospital has infectious disease ward, plus confirmation of the infection uh, by the investigation like RDT or net PCR, and uh, depending upon the parasitemia or the type of parasite or the infectious disease team would manage accordingly. Sometimes they in the exam they ask you the question, what are the indication of exchange in malaria patient?
Parasitemia more than 10%, um, and evidence of hemolysis.
If there
Yeah.
is cerebral malaria, it is an indication of uh, an exchange, red cell exchange. If the patient is severely ill with multiple organ involvement, or I think the parasitemia is more than 30%, not more than 10%, then usually the infectious disease approach you whether we can do red cell exchange for these such patients or not. So in the exam, you have to write your diagnosis as either Plasmodium falciparum or non-falciparum. Exam want a distinction between falciparum and non-falciparum only. They are not interested to say that this is Plasmodium vivax, Malaria, oval, anything like that. If you can differentiate between falciparum and non-falciparum, that is enough. And then uh, the heme base has given a table which differentiates the different species of Plasmodium from one another according to their red cell size, the thickness of the ring, multiple ring in the same cell, and the rings near to the uh, red cell membrane. They are called echolith. Plus, there is specific shape of Plasmodium falciparum gametocyte in the form of crescent or moon shape. Another important question is um, RDT principle, then is the indication of red cell exchange in malaria, and third one and the last one is uh, management. Plasmodium falciparum is usually managed by artesunate-based drugs. If you can remember that, that is good. I hope they would not ask more than this. And I have never heard that malaria has appeared in the Viva. So hopefully it will not come in the Viva this time as well.
Can I ask question, please?
Okay.
When we start reporting a blood film or normal aspirate, do we usually start with the abnormalities first, or do we just have a plan and go systematically? I
No,
get usually confused with this bit.
start what is prominent in the blood film.
Okay, okay,
Mm.
thank
So any abnormality which is evident in the blood film, start with that.
you. Okay, that's fine. Thank you.
सहर के भी नाम से आ रहा है यार.
So this second patient is 45-year-old boy um, whose blood sample has been referred to you by GP. So the patient is not in the hospital. You have received blood sample from the GP only, and the blood film shows white cell count of 66. hemoglobin of 129, and platelet count of 120.
What's that?
So anyone who wants to go ahead with this case? So the next person on the list is Devdutt. Devdutt, do you want to go ahead with this case?
Sure, no worry.
Okay. So this is the power 10, and then I will show you power 50 as well, and then you can report the blood thin.
Yeah, I'm just from this picture seems like that. Um, I can tell you. Okay, that's great image. 1 second, give me 1 second. I can see that one. Can you center? Can you make the visualize the center, please?
This much
I will
we
make it
like.
to 50, and then you can see them more clearly.
Yeah, it's little darker. Yeah, that's better. Exactly. Okay, stop it, please. Yeah. Okay. Mm,
Do you want me to go around?
yeah, from the red cells look like there are few spherocytes I can see in this red blood cell, but size look little smaller cell than the I can say that, and most of the you can and other you can see there is a lymphocytes. Their lymphocytes are the bigger, the different size of the lymphocytes. It look like some kind of immunoblast or something, but I'm not sure of the patient. But these look like lymphocyte, but there are no blast sign kind of picture look like.
The
Okay.
nucleus is mature, so they are
Yeah,
not blocked.
yeah. Dense
Okay. So I will,
chromatin. Yeah,
yeah,
you
I will,
can.
I will go around to show you more cells.
Yeah, yeah. The lymphocyte. This look few. I can see the microcytic cell. Few leptocyte cell, but hypochromic. Can you stop that, please? Okay, neutrophil band left shift. Okay. Hmm. This is the wood in the center on your left. I'm doubting myself. There's no
This
the third one center on your left, please.
third one, this one,
No, on your this if you there's a band neutrophil below the band neutrophil. Below the
this
band
one,
neutrophil. In the center below the band neutrophil. There is a band neutrophil. Below that
this
you can
one.
yeah yeah down one. Down please. Yeah, down one. If you move the arrow down in the slide, please. What kind of this seems like? Say, look. Yeah, this one. Where your hand? Yeah, this one. 1 second. Okay, lymphocyte look like okay. It look like lymphocyte. I think so. I'm not sure.
Mm.
Uh,
Right. So how would you report it?
Reporting. Okay, that's quite difficult part. I'm learning. Okay. But I'll tell you, the cells. I think that most of the cell look hypochromic macrocytic cell, and you can see the few of the spherocytes, but I can't see here the previous image I saw. And there is the abnormal shape lymphocyte, but I can see the large number of lymphocyte as compared. So would like to do the immunophenotyping. Okay, that's the only thing I can suggest. And
Oh,
platelet count is look. I see the size of platelet count look okay. Yeah. Anything else? I think so. That's
so
it.
this patient count is 66.
Mm, white blood cell. If you go through, there are the I think the leukocytosis with left shift and abnormal lymphocytes, and platelet look size is fine. Everything look okay. Nothing macrocytic hypochromic cell. Yeah, anemia. This okay. 45-year male. Yes. Anything else you can tell me? I can. But this
Oh.
is.
So these are all mature lymphocytes as the nuclear material is compact. They are dark looking. There is no nucleoli in them. These are mature lymphocytes. The patient white cell count is 66, and there are few spherocytes in the red cell as well. The platelet count is on lower side, and you have seen few smear cells as well in the um, in the slide.
Mm,
So you will say in your report that the blood film shows leukocytosis. The
mm,
leukocyte the leukocytes are mostly mature with no nucleoli and clear cytoplasm. Multiple smear cells are noted. The red cells morphology is okay except for few spherocytes. You cannot say whether they are small or big because there is no normal lymphocyte to compare with.
yeah. Okay. Okay. That's great.
No platelet clump seen, but the platelet count looks low. The blood film is most likely consistent with uh, a mature lymphoproliferative disease or proliferative disease, likely CLL. We need to send the blood to the flow for the flow to confirm our diagnosis. Right? This so
Yeah. But
you have mentioned the findings. You have suggested a probable diagnosis, and you have suggested some test as well to confirm your diagnosis. This will complete your report for the FRC path exam.
yeah.
Okay,
Okay. That's great.
fine. So, what is the expected flow cytometry for this case?
Expect. It's a lymphoproliferative disorder. CML. Mm. Yeah.
CLL,
I
chronic
think.
lymphocytic chronic lymphocytic leukemia, CLL.
I think CD200, CD34. If I remember correctly. I'm not sure if I remember correctly.
Okay. So, CLL has Matutes panel,
Mm.
which contains CD5 positive, CD23 positive,
CD.
CD43 positive, 200 positive, and surface immunoglobulin, which is weak.
Okay, not 30 or 43. Sorry. You're right. Okay, thank you.
So
Correct.
remember 5 23, 43, 200 for CLL. Then you
Yeah,
will not forget it.
yeah.
Okay.
It's
So,
43. Yeah.
yeah. So the last
AML.
question is, uh, you call the patient. Patient says he is completely fine. He has no B symptoms, no lymphadenopathy. He is doing his job normally, no problem with him. His white cell count is 66, and the flow cytometry confirm your diagnosis of CLL. Would
Mhm.
you like to treat this patient or not?
I think it depend upon the staging of the patient. If everything is fine, nothing is there, then likely I think WC count 76, and wait and watch. You can see choose, or you can just give. I think just wait and watch. Okay, let's see how you doing.
Yes, if CLL patient is asymptomatic, then no need to treat, just monitor the count. And the guidelines have some indications for treating the CLL patient. So you need to go through these points. What are the indications of um, treatment in CLL?
Yeah, sure, sure.
Yes. If lymphocyte count, if lymphocyte doubling time is less than 6 months, or if the lymphocyte increased by 50% in in 2 months or less than 2 months, if the patient start to develop progressive cytopenias, massive splenomegaly, and or massive lymph node which can compress the vital structures like any nerves, blood vessels. In such cases, you would think about starting the treatment for the patient.
Yeah, sure.
Okay.
Yeah, sure, sure. Thank you. That's 43. Sorry, 44 hours.
Dr. Amir, I have a question.
Yes, go ahead.
Why this case can't be a viral infection like by EBV infection as the cells are mature looking and they have abundant cytoplasm and their cytoplasm is scalping around the RBC? Why can't it be on morphology if we are not sure whether it's a lymphoproliferative disorder and we have a differential in our mind of a reactive process as well, and how we are going to report such case if we are have a doubt whether it's a clonal or it's a
Yeah.
reactive thing.
So I think I had shown you um, the infectious mononucleosis or reactive patient blood film. They do not have a count of 66. Their count is usually 11, 12, 13, 14, like this. Secondly, uh, the cytoplasm in reactive lymphocytes is a bit basophilic. This cytoplasm is very clear, and if you go towards thicker side, they become small and small, just like the typical CLL cell. You will not see such feature in the viral infection. Thirdly, like the question mentioned to you that you have called the patient says, I don't have any symptoms. If he had any viral infection, he would have told you that he had sore throat few days back, or he had a flu, or currently he has some infection going on. And the last supportive thing was that you, the question mentioned to you that the flow cytometry confirmed the diagnosis of CL. And in next lesson, we will see the infectious mononucleosis or reactive uh, blood film again to show you the difference between these cells and the infectious mononucleosis or reactive lymphocyte cells.
Okay. As the morphology of these cells is not very classic or typical of CLL.
Yes, but the cells are mature, and as you go towards thicker side, the size of the cells get shrink and small. CLL can have some prolymphocytes as well, which are bigger than normal, and they have nuclei as well. But this case, the cytoplasm was abundant, but the nucleus was very mature. But it was not basophilic as we usually see in the reactive lymphocytes. And the reactive lymphocytosis does not have counts like 66 or 76. The count was very high in this patient. You cannot call it as a reactive lymphocytosis.
Okay.
Okay, so now so this is the third case. This is a 41-year-old patient who had a bone marrow transplant for MDS with excess blood. He was well up till now, post transplant. His transplant was 2 years ago. Uh, you have seen him in the clinic today, and he was feeling a bit tired. You send a blood test for the patient, which shows pancytopenia, hemoglobin 88, white cell count 1.2, platelet count 88. And this is the blood film of the patient. So anyone who wants to go ahead?
Okay, I will do it. Amar. क्या हुआ?
Right. So this is the power 10. I will
Okay.
I will just move around, and then I will go to power 50. Because the patient is pancytopenic, we may not see a lot of cells in this slide.
What was the count? Could you repeat? What is the hemoglobin?
Hemoglobin 88,
Okay.
platelet 89, white cell count 1.2, neutrophil zero point 0.3.
Okay. Red cell are normal and iso. Occasional macrocytic cells are seen, and platelet appear reduced. Mm, I want to see any fragmentation because post-transplant must be on uh, immunosuppression. So is there any MAHA like because thrombocytopenia?
He has pancytopenia.
Yeah, it's pancytopenia. I can see clearly there are few macrocytes and otherwise it's normal and iso. And I can see neutrophil and few lymphoid cells. On this, in these pictures, I could not appreciate if there's any blast cells and platelets are reduced.
Do you think these neutrophils are normal?
This one is hypolobulated and hypogranular.
They are dysplastic.
Yeah, but few are like previously. This is atypical cell. I'm not sure whether it's a blast or, but it is definitely not normal. This could be blast.
So this one has a nucleoli.
Yes, this is blast.
So the blast percentage is 8%.
Okay. Yeah, blast. There are blast cells.
Right. So you'll see this one and then you can report the blood thin. So you
Yes,
now
blast.
you can start reporting the blood thin.
Yeah. The blood film shows mm, pancytopenia. Red cells are normocytic and iso. Occasional macrocytic RBCs can be appreciated. White cells are reduced, but there are blast cells present on the smear, and neutrophil are dysplastic, hypolobulated. Platelet on smear reduce, and otherwise, yes, this is at all. And film is conclusively suggestive of relapse as it's a post-transplant uh, slide.
Okay. So the blood film contain multiple blasts with
Yes,
uh, with low red cell count and low platelet count. There are multiple dysplastic neutrophil present as well. The
yes,
film raised the suspicion of a relapse disease post allogenic bone marrow transplant. We need to uh, admit, we need to do further investigation to confirm this relapse, like sending blood for flow cytometry and bone marrow aspirate and
Yes.
refine. Okay. So now I have told you that um, this patient has 8% blast and he has dysplastic neutrophils as well. And his previous disease was MDS with excess blast too. Do
Okay.
you think do you think this still fits in a category of MDS excess blast too?
Now it's a blast, but I have to check the bone marrow, not on the peripheral. Uh, on bone marrow, if the blast percentage are 10 to 19, then it's excess blast.
Plus, you have to check the um, cytogenetics as well,
Yeah,
whether the
cytogenetics,
patient has acquired any cytogenetic
no cytogenetic
abnormality
abnormality.
that that fits him into a category of AML. If
Okay.
not, then he will be a relapsed MDS excess blast too, because the blast percentage requirement for MDS excess blast 2 is 5 to 19% on peripheral blood and 10 to 19% in bone marrow.
Bone marrow.
Yeah. Okay. So the bone marrow has confirmed that this is relapsed MDS excess blast 2. And um, the question is, what is the treatment options here?
Yeah, it depends. Like, what is the again cytogenetics? It's a whether it's a good prognosis intermediate or poor prognosis IPSS. It's a low risk intermediate or high risk group, and patient has already received one allogenic transplant, and if the blast count is on lower side, like um, less than 20%, we can option we can discuss with the patient and previous treatment toxicities, patient performance status, comorbidities, and patient already received allogenic. Then second, uh, allo could be the possibility, or the hypomethylating agent could be the possibility, because the blast count is, as you said, it's on lower side.
Right. So you would say the patient
Or
need
supportive treatment.
yeah. So you would say the patient need reassessment
Yeah,
for fitness for any further chemotherapy,
yeah,
and the patient wishes as well whether he
yes,
want to have any further chemotherapy or not, either intensive or non-intensive. Assessment
yes,
of the patient organ function by doing routine blood tests, echo, LFTs, liver function tests, and his general condition because he may be frail
yes,
looking and not fit for any intensive chemotherapy. After that, uh, you can give him an option of um, uh, Ven-Aza because the blast percentage is less than 30%. You can give an option of a single agent, hydroxycarbamide, or you can palliate him
yeah,
after
uh,
discussing
yeah.
the patient in the MDT.
But Veneza is for AML. Can we give in this, like in guideline? Veneza is not mentioned in MDS.
Yes, Ven-Aza not here, but single agent you can give
Yeah,
to the patient.
hypomethylating agent, or uh, then there are other options like for palliative care, like low dose Ara-C and um,
Yes,
uh,
if depending upon the
other
patient fitness,
hypomethylating agents.
you can offer a single agent or a palliation for the patient. Okay,
Okay.
so MDS was not in the exam last time, so be ready for it this time.
Yes.
Oh. This is the second last case. Right. So this is again a GP sample. Uh, the BMS referred the blood film to you because he has seen multiple abnormal cells in the blood film. The full blood count of the patient is hemoglobin 110, white cell count of 26, and platelet count of 150. Okay. Who wants to go ahead?
Okay, I will do it if nobody else is ready.
Okay. Anyone can chip in.
Yes.
No issue.
Hmm.
Okay.
Yeah. You told hemoglobin 110 and platelet 150, and what about the TLC? It's 10,
It's 26.
26. Okay.
Okay. So this is the power 10. I will go to power 50.
Blood film red cells are normal and iso. And there are a few I can appreciate. I don't know, it's a few macrocytes like this, and the white cells are increased. Neutrophil are present, but they are hypogranular, and some dysplastic feature can also present. There is increase in monocyte count. There is monocytosis as well. Platelets are present. Yes, there are monocytes.
Okay. So now report the blood film.
Yeah, the film shows increased white cell count with the hypogranular hypodysplastic neutrophil and increase monocyte or monocytosis. Mm, red cells are normocytic and isocytosis, and platelets are adequate on film. Conclusively, blood film is suggestive of myeloproliferative or slash MDS um, neoplasm. Further investigation is required to confirm the diagnosis. Flow cytometry, bone marrow examination.
Sorry, what was your suggestion? That the film is
My
consistent with?
suggestion was film is suggestive of myeloproliferative neoplasm slash MDS. Or query. Can I mention here query CMML after
Yeah.
MP and MDS slash? Can I mention it's suggestive of CMML?
Yes. Why not?
Okay.
The blood film shows um, leukocytosis, which include some um, immature and mature monocytes, plus dysplastic neutrophils in the blood. The red cells are okay. The platelet count looks normal as well. The film is most likely consistent with a myeloproliferative uh, disorder like um CMML. We need to send the bloods for flow and need invasive investigation like bone marrow biopsy for confirmation. What is the WHO 2022 criteria for CMML diagnosis?
Uh, it is more than absolute monocyte count more than 1000, persistent more than 1000, or more than 10% monocyte of total WBC count. And there is no BCR, ABL, PV, ET, and primary myelofibrosis, and there is no myeloid lymphoid neoplasm in with the tyrosine kinase molecular uh, uh, defects. And there is this is the prerequisite, and then there is the supporting criteria. If the more than 1000 monocyte count, then any of the supporting three criteria is acceptable. But if it's monocyte count more than 0.5 but less than 1, then all three supporting criteria is present. Supporting criteria is dysplasia in one or more lineage, and there is a clonal cytogenetic abnormality and abnormal partitioning of monocyte. This is CD14 positive and 16 negative.
Yes. So the diagnostic requirement is that the patient should have monocytosis more than one, and plus either you should have a dysplastic lineage in one of the uh, cell, like we have neutrophil dysplasia here, or you should have a clonal genetic defect on bone marrow biopsy cytogenetics. Then uh, you have met the WHO 2022 criteria for diagnosis. This is CMML 1 or 2.
It is 2 because the WBC count is more than 13,000. If if more than 30,000, it is proliferative CMML. And if the blast count is less than 5% in the peripheral blood, then it is CMML1, and if it's more than 5% and less than 19%, then it is CMML, less than 20%, it is CMML2.
Yeah.
And in bone marrow, it is less than 10% if of 1, and more than 10%, but less than 19%, 20% in CMML2. So I would need the blast count in the peripheral blood. But
Yes, so
like,
subgrouping is on depends on the blast count, and
yes,
subtyping depend on the white cell count. If the white cell
okay,
count is more than 13, then it is a myeloproliferative CMML type. And if the blood count is less than 5% in peripheral blood, it is 1. If it is more than 5%, less than 19% in peripheral blood, it is CMML2.
yes.
Okay. So the last question is, what is the prognostic score that you use in CMML?
Prognostic score. Uh, I guess it is depend upon molecular lesions. SRSF2 is poor prognosis. XL1, ASXL1 is poor, and
I asked you what is the name of the score that you use for CMML prognostic score.
no, I think I don't.
CPSS mole.
Okay, CPSS.
CPSS mole, which include cytogenetics like ASXL1, NROS, RNX1, SETBP1, plus bone marrow blast count, peripheral blood white cell count, and transfusion dependency.
Okay.
Yeah, so this for CMML. It came in the last exam, so this time it can come in the Viva section or in the long cases uh, where it will convert to a full frank AML. So the last question, we'll do it quickly. Right, so this is a 55-year-old man uh, referred to you by the GP because of low counts and splenomegaly. So the next on the list is Nahid Khattak. Do you want to go ahead, Nahid?
Hello, yeah. Can you give me the counts, how much they are low, hemoglobin and TLC and platelets? Because the TLC seems to be quite high. Like it doesn't seem that it's the patient is having cytopenia.
So the hemoglobin is 98.
Okay,
White cell count is um, 8, 8 again, and platelet count is 130.
okay. The white cell count is 8,000.
Yes,
Okay,
this is the power 10,
okay.
and then I will go to uh, power 50. Just have a look. Now 50. The patient has somehow jolly as well because he has splenomegaly.
Okay. Yeah. The red cell seems to be normocytic and normochromic predominantly, and the white cells, they are mostly lymphocytes having abundant cytoplasm. Some of them are showing cytoplasmic projections as well, like hairy cells, and the platelet counts are. It seems to me normal, but yeah, they are like 150, 160.
Okay, report the blood film.
Okay. Red cells are normocytic, normochromic. Uh, WBC show predominantly lymphocytes having abundant cytoplasm. Uh, Chromatin is condensed. With condensed chromatin and abundant cytoplasm, having some of them, most of them showing cytoplasmic projections. Um, no neutrophils uh, seen so far. No neutrophils. Neutropenia, I can say, and platelets are adequate on film.
Why you say neutropenia? There were few neutrophils.
Yeah, but they were quite less as compared to the lymphocytes, and I didn't see the differential, but I think they are a bit low because
I think I
we
think
see
you
free.
you mean monocytopenia.
No, neutropenia, because I haven't seen, I saw only one, two neutrophils, and usually they are the predominant cells that we usually see on the film.
Oh. But
Mm,
I think there is no
okay,
monocytes in this film, which is the feature of this condition.
yeah, monocytopenia, yes, condition of, yeah, in hairy cell.
Okay.
So
So
I would
so the blood
advise flow
so the blood
cytometry.
film the blood film contains
Yeah,
multiple mature white cells with abundant cytoplasm and hairy projections.
yes,
There is monocytopenia. Some of the red cells shows power jolly bodies,
yeah,
signifying hypertenism.
yeah.
The platelet count looks uh, normal to low. There are no platelet clumps. The blood film is most likely consistent with
Lymphoproliferative disorder, most likely hairy cell leukemia.
with
Or we have to directly say that uh, hairy cell leukemia predominantly, like,
most likely consistent with hairy cell leukemia, which need to be confirmed on. further tests like flow cytometry and bone marrow aspirate and biopsy.
Yeah, and molecular as well for I don't know where they do it, BREF V600 mutation, which is
Okay.
present in 100, almost 100% of the patients of hairy cell.
Okay, right. So one of your colleague in this meeting says, no, Nahid is wrong. This is not hairy cell leukemia. This is hairy cell leukemia variant.
Okay.
How would you defend yourself that this is hairy cell leukemia, not variant?
In hairy cell leukemia variant, we usually have high WBC count. Uh, like it's, here the patient is are having like cytopenias, and in variant we usually have high WBC count. And I don't remember the other. There was a whole list of differences between hairy cell leukemia variant and hairy cell leukemia, but at the moment I don't remember any one of them. So
Okay.
yeah,
So for exam purpose, you need to remember that
okay,
the there is there is no hairy cell leukemia variant now if you are following WHO 2022.
okay,
It is called splenic lymphoma leukemia with prominent nucleoli, which
oh,
means that they have prominent nucleoli, less cytoplasm, no monocytopenia, leukocytosis, some difference in the flow cytometry, no BRAF V600E mutation. At least 4 or 5 differences are there.
yeah.
Okay. What flow cytometry do you expect in this case?
CD25 positive, 10311 C 10311C, 125, um, and
There,
B.
there is there is no marker as 125 yet.
Sorry, sorry, I'm a bit out of touch because I'm not actually preparing for part two, but I was listening it just for a part of passive learning.
Okay.
So
No,
yeah,
no worries. So it's 11C, so
yeah,
it's CD25,
yeah,
103, 1
yeah,
and 123. So this
yeah.
is the hairy cell panel which contain 4 markers.
Okay,
And what molecular mutations is present?
it's BREF one, BREF V600, and
BRAF, V600, and
yeah,
E. You have to write E as well, otherwise your answer will be wrong.
okay.
Yes. So would you like to treat this patient or not?
The patient, the counts are normal, like they are not that, if he is symptomatic because of the splenomegaly, or uh, as long as the patient is doing well, we don't treat him. But if the patient is having fever, or clinically he is symptomatic, then we usually treat the patients.
He is symptomatic. He has a big spleen to an extent that he has developed whole jollies in the
Ye-
blood film.
Yes.
Uh,
Ye-
right. So you have started him on the treatment. The last question is, how would you monitor the treatment response?
by first of all, by monitoring the if although he is asymptomatic, but we can see the changes in the blood counts, if they are like he's a bit cytopenic, so if they are improving, and by monitoring the size of the spleen.
You can monitor the patient either by flow, which is used not that common, or by repeating the bone marrow biopsy at 4 to 6 months to
Okay.
see whether your treatment has worked out or not.
So in the bone marrow, what we are going to see, like the percentage of cells or what?
So, do you know what are the features of hairy cell leukemia in a bone marrow?
Yeah, we usually like in the trephine biopsy, we see such these hairy cells have showing a particular feature going called fried egg appearance. That's quite like
Mm.
characteristic of it, and
Yeah.
fibrosis as well. So
So the trephine has fibrosis,
yes,
fried egg appearance of the hairy cells, and
yes,
the aspirate is very difficult to get from these patients. The
yeah,
aspirate is a dry type usually. If your
yeah.
patient is responding to the treatment, you would be able to get some aspirate after 4 months or after 6 months.
Okay, okay,
Yeah. So the dry nature of the tap would go down. And if you revive their um, bone marrow biopsy and the trephine, the fibrosis content would have gone down as
okay, yeah, okay,
well. Right?
all right.
Right. So this was the session 5 for morphology, and the next slide is that these sessions are all free, and I want to keep them free. But if you want to donate, these are the account details. And the last thing is that thank you, and please like, share, and subscribe the channel. And we will meet next Sunday again with another 5 cases.
Thank you very
Thank
much.
you.
That was great. Thank you.
Thank you.
Welcome. Take
Full.
care.
Thank you.